Welcome to part 2 of clinical enzymology. In this chapter class, we will be talking about all the different types of enzymes that is found in our body, their classifications, their diagnostic significance, and the different analysis or tests that are used to determine these different enzymes. We will be discussing the commonly analyzed enzymes, including their systematic names and clinical significance. Each enzyme is discussed in this chapter with respect to tissue source, diagnostic significance, assay method, source of error, and reference range. You may take a screenshot of this table, or if you have the Bishop's book, Clinical Chemistry, then this is found at page 270, table 13.2, the major enzymes of clinical significance. This will also go out in our examination class, the type of enzyme and their clinical significance. So you have to make sure to memorize the enzymes and the diseases associated with it. Let's start with the phosphatases. Alkaline phosphatase belongs to a group of enzymes that catalyze the hydrolysis of various phosphomonoethers at an alkaline pH. Consequently, ALP is a non-specific enzyme capable of reacting with many different substrates. Specifically, alkaline phosphatase functions to liberate inorganic phosphate from an organic phosphate ester with the concomitant production of an alcohol. The optimal pH for this reaction is at 9 to 10, but optimal pH varies with the substrate used. The enzyme also requires magnesium as an activator. ALP activity is present on cell surfaces in most human tissue, but the highest concentrations are found in the intestine, liver, bone, spleen, placenta, and kidney. In the liver class, the enzyme is located on both sinusoidal and bile canalicular membranes. While the activity in bone, it is purely confined to the osteoblast. So osteoblasts, these are cells involved in the production of the bone matrix. The specific location of the enzyme within this tissue accounts for the more predominant elevations in certain disorders. The elevations of ALP are of most diagnostic significance in the evaluation of hepatobiliary and bone disorders. In hepatobiliary disorders, elevations are more predominant in obstructive conditions than in hepatocellular disorders. In bone disorders, elevations are observed when there is involvement of the osteoblast. In biliary tract obstruction, alkaline phosphatase levels range from 3 to 10 times the upper limit, and the increases are primarily a result of increased synthesis of the enzyme induced by cholestasis. In contrast, hepatocellular disorders such as hepatitis and cirrhosis show only slight increase, usually less than 3 times the upper limit. Because of the degree of overlap of alkaline phosphatase elevations that occurs in the various liver disorders, a single elevated ALP level is difficult to interpret. It assumes more diagnostic significance when evaluated along with other tests of hepatic function. Elevated alkaline phosphatase levels may be observed in various bone disorders. Perhaps the highest elevations of ALP activity occurs in Paget's disease, or otherwise known as otitis deformans. Other bone disorders include osteomalacia, rickets, hyperparathyroidism, and osteogenic sarcoma. In addition, increased levels are also observed in healing bone fractures and during periods of physiologic bone growth. In normal pregnancy, increased ALP activity averaging approximately 1.5 times the upper limit can be detected between weeks 16 and 20 and is 2 to 3 times the upper limit during the third trimester. ALP activity increases and persists until the onset of labor. Activity then returns to normal within 3 to 6 days. Elevations also may be seen in complications of pregnancy, such as hypertension, preeclampsia, and eclampsia, as well as in threatened abortion. Alkaline phosphatase levels are significantly decreased in the inherited condition of hypophosphatasia. Subnormal activity is a result of the absence of the bone isoenzyme and results in inadequate bone calcification. ALP exists as a number of isoenzymes which have been studied by a variety of techniques. The major isoenzymes which are found in the serum and have been most extensively studied are those that derive from the liver, bone, intestine, and placenta. Electrophoresis is considered the most useful single technique for alkaline phosphatase isoenzyme analysis. However, because there may still be some degree of overlap between the fractions, electrophoresis in combination with another separation technique may provide the most reliable information. A direct immunochemical method for the measurement of bone-related alkaline phosphatase is now available, and this has made ALP electrophoresis unnecessary in most cases. The liver fraction migrates the fastest, followed by bone, placental, and intestinal fractions. Because of the similarity between liver and bone phosphatases, there often is not a clear separation between them. Quantitation with use of a densitometer is sometimes difficult because of the overlap between the two peaks. The liver isoenzyme can actually be divided into two fractions, the major liver band and a smaller fraction called the fast liver or alpha 1 liver, which migrates anodal to the major band and corresponds to the alpha 1 fraction of protein electrophoresis. When total ALP levels are increased, the major liver fraction is the most frequently elevated. Many hepatobiliary conditions cause elevations of this fraction, usually early in the course of the disease, while the fast liver fraction has been reported in metastatic carcinoma of the liver as well as in other hepatobiliary diseases. Its presence is regarded as a valuable indicator of obstructive liver disease. However, it is occasionally present in the absence of any detectable disease states. The bone isoenzyme increases due to osteoblastic activity and is normally elevated in children during periods of growth and in adults older than 50. In these cases, an elevated ALP level may be difficult to interpret. The presence of intestinal ALP isoenzyme in serum depends on the blood group and secretor status of the individual. Usually, individuals who have B or O blood group and are secretors are more likely to have this fraction. Apparently, intestinal alkaline phosphatase is bound by erythrocytes of Group A or blood type A. Furthermore, if these individuals, increases in intestinal alkaline phosphatase occur after consumption of a fatty meal. Intestinal alkaline phosphatase may also increase in several disorders, such as diseases of the digestive tract and cirrhosis. Increased levels are also found in patients undergoing chronic hemodialysis. Difference in heat stability is the basis of a second approach used to identify the isoenzyme source of an elevated alkaline phosphatase. Typically, alkaline phosphatase activity is measured before and after heating the serum at 56 degrees Celsius for 10 minutes. If the residual activity after heating is less than 20% of the total activity before heating, then the ALP elevation is assumed to be a result of bone phosphatase. If greater than 20% of the activity remains, the elevation is probably a result of liver phosphatase. These results are based on the finding that placental alkaline phosphatase is the most heat stable of the four major fractions, followed by intestinal, liver, and bone fractions in decreasing order of heat stability. Placental alkaline phosphatase will resist heat denaturation at 65 degrees Celsius for 30 minutes. Heat inactivation is an imprecise method for differentiation because inactivation depends on many factors such as correct temperature control, timing, and analytic methods sensitive enough to detect small amounts of residual alkaline phosphatase activity. In addition, there is some degree of overlap between heat and activation of liver and bone fractions in both liver and bone diseases. Aside from electrophoresis, the heat inactivation or heat stability test, the third approach to identification of alkaline phosphatase isoenzymes is based on selective chemical inhibition. Phenylalanine is one of several inhibitors that have been used, and phenylalanine class inhibits intestinal and placental alkaline phosphatase to a much greater extent than liver and bone ALT. With phenylalanine use, however, it is impossible to differentiate placental from intestinal ALP or liver from bone ALP. In addition to the four major ALP isoenzyme fractions, certain abnormal fractions are associated with neoplasms or cancer. The most frequently seen are the Reagan and Nagao isoenzymes. They have been referred to as carcinoplacental alkaline phosphatases because of their similarities to the placental isoenzyme. The frequency of occurrence ranges from 3 to 15% in cancer patients. The Reagan isoenzyme has been characterized as an example of an ectopic production of an enzyme by malignant tissue. It has also been detected in various carcinomas such as lung, breast, ovarian, and colon, with the highest incidences in ovarian and gynecologic cancers. Because of its low incidence in cancer patients, diagnosis of malignancy is rarely based on its presence. It is, however, useful in monitoring the effects of therapy because it will disappear on successful treatment. The Reagan isoenzyme migrates to the same position as the bone fraction and is the most heat stable of all ALP isoenzymes, resisting denaturation at 65 degrees Celsius for 30 minutes. Its activity is also inhibited by phenylalanine. While the Nagao isoenzyme may be considered a variant of the Reagan isoenzyme, its electrophoretic, heat stability, and phenylalanine inhibition properties are identical to those of the Reagan fraction. And however, Nagao also can be inhibited by L-leucine, and its presence has been detected in metastatic carcinoma of pleural surfaces and in adenocarcinoma of the pancreas and bile duct. Because of the relative nonspecificity of alkaline phosphatase with regard to substrates, a variety of methodologies for its analysis have been proposed and are still in use today. The major differences between these relate to the concentration and types of substrate and buffer used and the pH of the reaction. A continuous monitoring technique based on a method devised by Bowers and McComb allows calculation of alkaline phosphatase activity based on the molar absorptivity of para-nitrophenol. Para-nitrophenyl phosphate is colorless, and it also hydrolyzes to para-nitrophenol, which gives off a yellow color, and the increase in absorbance at 405 nanometers, which we will be observing soon, is directly proportional to the alkaline phosphatase activity. These are the other tests used in order to detect the activity of alkaline phosphatase in the patient samples. From Bodansky, Shinowara, Jones, and Reinhardt, all of these tests uses beta-glycerophosphate as a substrate, while the end products would be inorganic phosphate and glycerol. King and Armstrong uses phenylphosphate as a substrate, and the end product would be phenol. For Bessie, Lowry, and Brock, and at the same time Bowers and McComb, they use paranitrophenyl phosphate as a substrate. The end products would be paranitrophenol. For Huggins and Talalay, the substrate used is phenolphthalein diphosphate, and the end product would be phenolphthalein red. Moss makes use of alpha-naphthol phosphate as a substrate, and the end product would be alpha-naphthol. For Klein, Bobson, and Reed, they make use of buffered phenolphthalein phosphate as the substrate, and the end product would be free phenolphthalein. The sources of error, number one, would be hemolysis. This may cause slight elevations because alkaline phosphatase is approximately 6 times more concentrated inside the erythrocytes than in serum. ALT assays should be run as soon as possible after collection. Activity in serum increases approximately 3 to 10% on standing at 25 degrees Celsius or 4 degrees Celsius for several hours. Diet may also induce elevations in alkaline phosphatase activity of blood group B and O individuals who are secretors. Values may be 25% higher following ingestion of a high-fat meal. The following values presented are the reference ranges for total alkaline phosphatase levels at 37 degrees Celsius. Next would be acid phosphatases. It belongs to the same group of phosphatase enzymes as alkaline phosphatase and is also considered a hydrolase that catalyzes the same type of reactions. The major difference between acid phosphatase and alkaline phosphatase by the name itself is the pH of the reaction. Acid phosphatase functions at an optimal pH of approximately 5. ACP activity is found in the prostate, bone, liver, spleen, kidney, erythrocytes, and platelets. The prostate is the richest source with many times the activity found other than in the other organs or tissue. Historically, acid phosphatase measurement has been used as an aid in the detection of prostatic carcinoma, particularly metastatic carcinoma of the prostate. Total ACP determinations are relatively insensitive techniques, detecting elevated ACP levels resulting from prostatic carcinoma in the majority of cases only when the tumor has already metastasized. Newer markers such as prostate-specific antigen are more useful screening and diagnostic tools. One of the most specific substrates for prostatic acid phosphatase is thiolphthalin monophosphate. Chemical inhibition methods used to differentiate the prostatic portion most frequently use tartrate as the inhibitor. The prostatic fraction of ACP is inhibited by tartrate. Serum and substrates are incubated both with and without the addition of L-tartrate, or that's levotartrate. ACP activity remaining after inhibition with L-tartrate is subtracted from the total ACP activity determined without inhibition, and the difference represents the prostatic portion. The reaction is not entirely specific for prostatic acid phosphatase. Lysosomal ACP is also inhibited by tartrate. However, other tissue sources are largely uninhibited. Neither of these methods of ACP determination is sensitive to prostatic carcinoma that has not metastasized. Values are usually normal in the majority of the cases, and in fact, may be elevated only in about 50% of the cases of prostatic carcinoma that has metastasized. One technique with much improved sensitivity over conventional ACP assays is the immunologic approach using antibodies that are specific for the prostatic portion. Immunochemical techniques, however, are not of value as screening tests for prostatic carcinoma. PSA, or prostate-specific antigen, is more likely than ACP to be elevated at each stage of prostatic carcinoma, even though a normal PSA level may be found in stage D tumors. Prostate-specific antigen is particularly useful to monitor the success of treatment. However, PSA is controversial as a screening test for prostatic malignancy because PSA elevations may occur in conditions other than prostatic carcinoma, such as benign prostatic hypertrophy and prostatitis. Other prostatic conditions in which ACP elevations have been reported include hyperplasia of the prostate and prostatic surgery. There are also conflicting reports of elevations following rectal examination and prostate massage. Certain studies have reported ACP elevations, and others have indicated no detectable change. When elevations are found, levels usually return to normal within 24 hours. ACP assays have proved useful in forensic clinical chemistry, particularly in the investigation of rape. Vaginal washings are examined for seminal fluid and also ACP activity, which can persist for up to 4 days. Elevated activity is presumptive evidence of rape in such cases. Serum ACP activity may frequently be elevated in bone diseases as well. Activity has been shown to be associated with the osteoclasts. Elevations have been noted in Paget's disease, in breast cancer with bone metastasis, and in Gaucher's disease, in which there is an infiltration of bone marrow and other tissue by Gaucher cells rich in ACP activity. Because of ACP activity in platelets as well, elevations are observed when platelet damage occurs, as in the thrombocytopenia resulting from excessive platelet destruction from idiopathic thrombocytopenic purpura. Assay procedures for total ACP use the same techniques as in alkaline phosphatase assays, but are performed at an acid pH. So that's para-nitrophenol phosphate, and then acid phosphatase reacts to this substrate using the pH of 5, gives off a product of para-nitrophenol and phosphate ion. The reaction products are colorless at the acid pH of the reaction, but the addition of alkali stops the reaction and transforms the products into chromogens, which can be measured spectrophotometrically. These are the other assays to check for ACP activity. That would be Guttman and Guttman. The substrate used is phenyl phosphate, and the end product would be inorganic phosphate. Shinowara makes use of para-nitrophenyl phosphate, and the end product would be para-nitrophenol. Babson, Reed, and Phillips makes use of a continuous monitoring or kinetic assay that makes use of alpha-naphthyl phosphate as a substrate, and the end product would be alpha-naphthol. Roy and Hillman makes use of thymolphthalein monophosphate as the substrate, with the end product of free thymolphthalein. Rates and Goldbot makes use of 4-methyl-umbelliferone as the substrate, and the end product would be a fluorescence. Among all those class, thymolphthalein monophosphate is the substrate of choice for quantitative endpoint reactions. But for continuous monitoring methods, alpha naphthyl phosphate is more preferred. Immunochemical techniques for prostatic ACP use several approaches that includes radioimmunoassay, counter-immunoelectrophoresis, and immunoprecipitation. Also, an immunoenzymatic assay for tandem E includes incubation with an antibody to prostatic acid phosphatase, followed by washing and incubation with para-nitrophenyl phosphate. The para-nitrophenol formed is measured photometrically and is proven to be proportional to the prostatic ACP in the sample. Serum class should be separated from the red cells as soon as the blood has already clotted. That is to prevent leakage of erythrocyte and platelet acid phosphatase. Serum activity decreases within 1 to 2 hours if the sample is left at room temperature without the addition of a preservative. Decreased activity is a result of a loss of carbon dioxide from the serum, with a resultant increase in pH. If not assayed immediately, serum should be frozen or acidified to a pH lower than 6.5. With acidification, ACP is stable for 2 days at room temperature. Hemolysis as well should be avoided because of contamination from erythrocyte acid phosphatase. Radioimmunoassay procedures for measurement of prostatic ACP require non-acidified serum samples. The activity is stable for 2 days at 4 degrees Celsius. The reference values for prostatic ACP would be 0 to 3.5 nanograms per ml. While for tartrate-resistant acid phosphatase in adults, it would be 1.5 to 4.5 units per liter. That's at 37 degrees Celsius. While for tartrate-resistant ACP in children, that would be 3.5 to 9 units per liter at 37 degrees Celsius. For the transaminases or transferases, we have two: aspartate aminotransferase and alanine aminotransferase. Aspartate aminotransferase is commonly referred to as a transaminase and is involved in the transfer of an amino group between aspartate and alpha keto acids. The older term used to AST is serum glutamic oxaloacetic transaminase, or SGOT or GOT. You can also use interchangeably all those terms. Pyridoxal phosphate functions as a coenzyme. Just a brief recap. What's a coenzyme again? Yes, it's an organic compound or otherwise known as second substrates. Remember, they're organic cofactors. While a cofactor, if you can remember from the previous discussion, cofactors are non-protein entities that are required to bind to particular enzymes before a reaction occurs. The transamination reaction is important in intermediary metabolism because of its function in the synthesis and degradation of amino acids. The keto acids formed by the reaction are ultimately oxidized by the tricarboxylic acid cycle to provide a source of energy. By the way, class, aspartate aminotransferase is widely distributed in human tissue, but the highest concentrations are found in cardiac tissue, liver, and skeletal muscle, with smaller amounts found in the kidney, pancreas, and erythrocytes. The clinical use of AST is limited mainly to the evaluation of hepatocellular disorders and skeletal muscle involvement. In acute myocardial infarction, AST levels begin to rise within 6 to 8 hours, which peaks at 24 hours and generally return to normal within 5 days. However, because of the wide tissue distribution, AST levels are not useful in the diagnosis of AMI. AST elevations are frequently seen in pulmonary embolism. Following congestive heart failure, AST levels also may be increased, probably reflecting liver involvement as a result of inadequate blood supply to that organ. AST levels are highest in acute hepatocellular disorders. In viral hepatitis, levels may reach 100 times the upper limit, and in cirrhosis, only moderate levels, approximately 4 times the upper limit. Skeletal muscle disorders such as the muscular dystrophies and inflammatory conditions also cause increase in AST levels around 4 to 8 times the upper limit. Before I forget class, AST exists as two isoenzyme fractions located in the cell cytoplasm and mitochondria. The intracellular concentration of AST may be 7,000 times higher than the extracellular concentration. The cytoplasmic isoenzyme is the predominant form occurring in serum. So meaning in disorders producing cellular necrosis, the mitochondrial form may be significantly increased. Isoenzyme analysis of AST is not routinely performed in the clinical laboratory. The assay methods for AST are generally based on the principle of the Karman method, which incorporates a coupled enzymatic reaction and monitors the change in absorbance at 340 nanometers continuously as NADH is oxidized to NAD+. The optimal pH is 7.3 to 7.8. Hemolysis also should be avoided because it can dramatically increase serum AST concentration. AST activity is stable in serum for 3 to 4 days at refrigerated temperatures. The reference range would be 5 to 35 U per liter at 37 degrees Celsius or 0.1 to 0.6 microcatal per liter. Next would be alanine aminotransferase. For alanine aminotransferase class, it is a transferase with enzymatic activity similar to that of AST. Specifically, it catalyzes the transfer of an amino group from alanine to alpha ketoglutarate with the formation of glutamate and pyruvate. The older terminology of ALT is serum glutamic pyruvic transaminase, or SGPT or GPT. Above is the reaction of alanine aminotransferase. It makes use also of pyridoxal phosphate as the coenzyme. Alanine aminotransferase is distributed in many tissues with comparatively high concentrations in the liver. It is considered the more liver-specific enzyme of all the transferases. Clinical applications of alanine aminotransferase assays are confined mainly to evaluation of hepatic disorders. Higher elevations are found in hepatocellular disorders than in extrahepatic or intrahepatic obstructive disorders. In acute inflammatory conditions of the liver, ALT elevations are frequently higher than those of AST and tend to remain elevated longer as a result of the longer half-life of ALT in serum. That's around 16 to 24 hours. Cardiac tissue contains a small amount of alanine aminotransferase activity, but the serum level usually remains normal in acute myocardial infarction unless subsequent liver damage has occurred. Alanine aminotransferase levels have historically been compared with levels of AST to help determine the source of an elevated AST level and to detect liver involvement concurrent with myocardial injury. The typical assay procedure for alanine aminotransferase consists of a coupled enzymatic reaction using lactate dehydrogenase as the indicator enzyme, and which catalyzes the reduction of pyruvate to lactate with the simultaneous oxidation of nicotinamide adenine dinucleotide plus hydrogen. The change in absorbance at 340 nanometers measured continuously is directly proportional to the ALT activity. The optimal pH for this is 7.3 to 7.8. AST class is stable for 3 to 4 days at 4 degrees Celsius, and it is relatively unaffected by hemolysis. The reference range for ALT is also 7 to 45 units per liter at 37 degrees Celsius. This slide here, class, will show us the summary of the differences between aspartate aminotransferase and alanine aminotransferase. This will make you study easier and at the same time understand the differences between their usage in the body. It's also shown here that since AST and ALT catalyzes the same reaction, they also have the same methods, that's Reitman and Frankel. This slide here are also the notes to remember for transferases or transaminases. By the way, what's a de-Ritis ratio? De-Ritis ratio is the ratio of serum aspartate aminotransferase to serum alanine aminotransferase. This has been proposed as a valuable diagnostic marker to screen liver disorder. The objective of this de-Ritis ratio class is to assess the significance of de-Ritis ratio as a diagnostic marker in population of hepatic disorder. A normal AST-ALT ratio should be less than 1. In patients with alcoholic liver disease, the AST-ALT ratio is more than 1 in 92% of patients and more than 2 in 70%. AST-ALT scores more than 2 are therefore strongly suggestive of alcoholic liver disease. The next enzyme would be amylase. Amylase is an enzyme belonging to the class of hydrolases that catalyze the breakdown of starch and glycogen. Starch consists of both amylose and amylopectin. Amylose is a long and branched chain of glucose molecules linked by alpha-1,4 glycosidic bonds, while amylopectin is a branched chain polysaccharide with alpha-1,6 linkages at the branch points. The structure of glycogen is similar to that of amylopectin but is more highly branched. Alpha amylase attacks only the alpha-1,4 glycosidic bonds to produce degradation products consisting of glucose, maltose, and intermediate chains called dextrins. These dextrins class contains alpha-1,6 branching linkages. Cellulose and other structural polysaccharides consisting of linkages are not attacked by alpha amylase. Amylase is therefore an important enzyme in the physiologic digestion of starch. This is how amylase would degrade amylopectin or amylose into glucose, maltose, or dextrins. Amylase also requires calcium and chloride ions for its activation. The acinar cells of the pancreas and the salivary glands are the major tissue sources of serum amylase. Lesser concentrations are found in skeletal muscle and the small intestine as well as the fallopian tubes. Amylase is the smallest enzyme with a molecular weight of 50,000 to 55,000 Daltons. Because of its small size, it is readily filtered by the renal glomerulus and also it can appear in the urine. Digestion of starches begins in the mouth with the hydrolytic action of salivary amylase. The salivary amylase activity, however, is of short duration because on swallowing, it is inactivated by the acidity of the gastric contents. Pancreatic amylase then performs the major digestive action of starch once the polysaccharides reach the intestine. The diagnostic significance of serum and urine amylase measurements is in the diagnosis of acute pancreatitis. Disorders of tissue other than the pancreas can also produce elevations in amylase levels. Therefore, an elevated amylase level is a non-specific finding. However, the degree of elevation of amylase is helpful to some extent in the differential diagnosis of acute pancreatitis. In addition, other laboratory tests such as measurements of urinary amylase levels, amylase clearance studies, amylase isoenzyme studies, and measurements of serum lipase levels when used in conjunction with serum amylase measurement. The increased specificity of amylase measurements is very helpful in the diagnosis of acute pancreatitis. In acute pancreatitis class, serum amylase levels begin to rise 5 to 10 hours after the onset of an attack, and it peaks at 24 hours and returns to normal levels within 3 to 5 days. Values generally range from 250 to 1,000 Somogy units per deciliter. The values can reach much higher levels as well. Other disorders causing an elevated serum amylase level include salivary gland lesions such as mumps, parotitis, and other intra-abdominal diseases such as perforated peptic ulcer, intestinal obstruction, cholecystitis, ruptured ectopic pregnancy, mesenteric infarction, and acute appendicitis. In addition, elevations have been reported in renal insufficiency and diabetic ketoacidosis. Serum amylase levels in intra-abdominal conditions other than acute pancreatitis are usually less than 500 Somogy units per deciliter. An apparently asymptomatic condition of hyperamylasemia has been noted in approximately 1 to 2% of the population. Hyperamylasemia can occur in neoplastic diseases with elevated results as high as 50 times the upper limit. Macroamylasemia is a condition that results when the amylase molecule combines with immunoglobulins to form a complex that is too large to be filtered across the glomerulus. Serum amylase levels increase because of the reduction in normal renal clearance of the enzyme, and consequently, the urinary excretion of amylase is abnormally low. The diagnostic significance of macroamylasemia lies in the need to differentiate it from other causes of hyperamylasemia. Much interest has been focused recently on the possible diagnostic use of amylase isoenzyme measurements. Serum amylase is a mixture of a number of isoenzymes that can be separated on the basis of differences in physical properties, most notably in electrophoresis, although chromatography and isoelectric focusing also have been applied. In normal human serum, 2 major bands and as many as 4 minor bands may be seen. The bands are designated as P-type and S-type isoamylase. The P-isoamylase is derived from the pancreatic tissue, while the S-type isoamylase is derived from salivary gland tissue as well as the fallopian tube and the lung. The isoenzymes of salivary origin that consist of S1, S2, and S3 migrate most quickly, whereas those of pancreatic origin, P1, P2, and P3 are slower. In normal human serum, the isoamylases migrate in regions corresponding to the beta until to the alpha globulin regions of protein electrophoresis. And the most commonly observed fractions are P2, S1, and S2. In acute pancreatitis, there is typically an increase in P-type activity, with P3 being the most predominant isoenzyme. However, P3 also has been detected in cases of renal failure and therefore is not entirely specific for acute pancreatitis. The S-type isoamylase represents approximately two-thirds of amylase activity of normal serum, whereas P-type predominates in normal urine. Amylase can be assayed by a variety of different methods, which is summarized in this table. The four main approaches are categorized as amyloclastic, sacchαρογenic, chromogenic, and continuous monitoring. For now class, continuous monitoring has replaced previous methods for amylase activity. In the amyloclastic method, amylase is allowed to act on a starch substrate to which iodine has been attached. As amylase hydrolyzes the starch molecule into smaller units, the iodine is released and a decrease occurs in the initial dark blue color intensity of the starch-iodine complex. The decrease in color is proportional to the amylase concentration. The sacchαρογenic method uses a starch substrate that is hydrolyzed by the action of amylase to its constituent carbohydrate molecules that have been reducing properties. The amount of reducing sugars is then measured where the concentration is still the same proportional to amylase activity. The sacchαρογenic method is the classic reference method for determining amylase activity and is reported in Somogyi units. Somogyi units are an expression of the number of milligrams of glucose released in 30 minutes at 37 degrees Celsius under specific assay conditions. Chromogenic methods use a starch substrate to which a chromogenic dye has been attached, forming an insoluble dye-substrate complex. As amylase hydrolyzes the starch substrate, smaller dye-substrate fragments are produced, and these are water-soluble. The increase in color intensity of the soluble dye-substrate solution is proportional to amylase activity. Recently, class, coupled enzyme systems have been used to determine amylase activity by a continuous monitoring technique in which the change in absorbance of nicotinamide adenine dinucleotide plus at 340 nanometers is measured. For this reaction, this amylase activity, the optimal pH is 6.9. Because salivary amylase is preferentially inhibited by wheat germ lectin, salivary and pancreatic amylase can be estimated by measuring total amylase in the presence and absence of lectin. Specific immunoassays are also available for measuring isoenzymes of amylase. Amylase in serum and urine is stable, while little loss of activity occurs at room temperature for 1 week or at 4 degrees Celsius for 2 months. Because plasma triglycerides suppress or inhibit serum amylase activity, amylase values may be normal in acute pancreatitis with hyperlipemia. The administration of morphine and other opiates for pain relief before blood sampling will lead to falsely elevated serum amylase levels. The drugs presumably cause constriction of the sphincter of Oddi and of the pancreatic ducts, with consequent elevation of inarticulate pressure causing regurgitation of amylase into the serum. Before I proceed to the next enzyme, I want you to know the clinical significance of getting the urine amylase creatinine ratio. It is because, class, when there is an elevated amylase creatinine clearance ratio, this has been a very big help to establish the diagnosis of acute pancreatitis. It has also been said that urinary amylase excretion was found to be a more sensitive and reliable index than amylase concentration in serum or urine for the diagnosis of acute pancreatitis, also of chronic pancreatitis, and of carcinoma. For lipase class, It is an enzyme that hydrolyzes the ester linkages of fats to produce alcohols and fatty acids. Specifically, lipase catalyzes the partial hydrolysis of dietary triglycerides in the intestine to the 2-monoglyceride intermediate with the production of long-chain fatty acids. The enzymatic activity of pancreatic lipase is specific for the fatty acid residues at positions 1 and 3 of the triglyceride molecule. But substrate must be an emulsion for the activity to occur. The reaction rate is accelerated by the presence of colipase and a bile salt. Lipase concentration is found primarily in the pancreas, although it is present in the stomach and small intestine. Clinical assays of serum lipase measurements are confined almost exclusively to the diagnosis of acute pancreatitis. Serum lipase activity increases 4 to 8 hours after an attack of acute pancreatitis, and the concentrations peak at 24 hours and decreases within 8 to 14 days. Lipase is similar in this respect to amylase measurements, but is considered more specific for pancreatic disorders than amylase measurement. Both amylase and lipase levels rise quickly, but lipase elevations persist for approximately 8 days in acute pancreatitis, whereas amylase elevations persist for only 2 to 3 days. The extent of elevations does not correlate with the severity of the disease. Elevated lipase levels also may be found in other intra-abdominal conditions, but with less frequency than elevations of serum amylase. Elevations have been reported in cases of penetrating duodenal ulcers and perforated peptic ulcers, intestinal obstruction, and acute cholecystitis. In contrast class to amylase levels, lipase levels are normal in conditions of salivary gland involvement. Therefore, lipase levels are useful in differentiating serum amylase elevation as a result of pancreatic versus salivary involvement. Of the three lipase isoenzymes, L2 is thought to be the most clinically specific and sensitive. Just to broaden your knowledge, isoenzymes of lipase comes from the pancreatic juice and serum of patients with acute pancreatitis. So, lipase has three isoenzymes, that's L1 and L2, which are pancreatic isoenzymes or isoforms. And there is also L3. L3 is called the pancreatic carboxyl ester lipase, also known as cholesterol esterase. The procedure used to measure lipase activity include estimation of liberated fatty acids, so that's through titrimetric and turbidimetric methods. Early methods for lipase were historically poor. The classic cherry crandall method used an olive oil substrate and measured the liberated fatty acids by titration after a 24-hour incubation. Modifications of the cherry crandall method have been complicated by the lack of stable and uniform substrates. However, triolein is one substrate now used as a more pure form of triglyceride. Turbidimetric methods are simpler and more rapid than titrimetric assays. Fats in solution create a cloudy emulsion, and as the fats are hydrolyzed by lipase, the particles disperse, and the rate of clearing can be measured as an estimation of the lipase activity. Colorimetric methods are also available and are based on coupled reactions with enzymes such as peroxidase or glycerol kinase. Lipase class is stable in serum with negligible loss in activity at room temperature for 1 week or for 3 weeks at 4 degrees Celsius. Hemolysis should also be avoided because hemoglobin inhibits the activity of serum lipase, causing falsely low values. The reference range for lipase would be less than 38 units per liter at 37 degrees Celsius. The next enzyme that is of clinical significance is the lactate dehydrogenase. It is an enzyme that catalyzes the interconversion of lactic and pyruvic acids. It is a hydrogen transfer enzyme that uses the coenzyme nicotinamide adenine dinucleotide. Lactate dehydrogenase is widely distributed in the body. High activities are found in the heart, liver, skeletal muscle, kidney, and red blood cells. Lesser amounts are found in the lung, smooth muscle, and the brain. Because of its widespread activity in numerous body tissue, lactate dehydrogenase is elevated in a variety of disorders. Increased levels are found in cardiac, hepatic, and skeletal muscle, and even in renal diseases, as well as in several hematologic and neoplastic disorders. The highest levels of total lactate dehydrogenase are seen in pernicious anemia and hemolytic disorders. Intramedullary destruction of erythroblasts causes elevation as a result of the high concentration of lactate dehydrogenase in erythrocytes. Liver disorders such as viral hepatitis and cirrhosis show slight elevations of 2 to 3 times the upper limit. Acute myocardial infarction and pulmonary infarct also show slight elevations of approximately the same degree, around 2 to 3 times the upper limit. In AMI, lactate dehydrogenase levels begin to rise within 12 to 24 hours. They reach its peak levels within 48 to 72 hours and may remain elevated for 10 days. Skeletal muscle disorders and some leukemias contribute to increased levels. Marked elevations can be observed in most patients with acute lymphoblastic leukemia in particular. Because of the many conditions that contribute to increased activity, an elevated total lactate dehydrogenase value is a rather nonspecific finding. LD assays, therefore, assume more clinical significance when separated into isoenzyme fractions. The enzyme can be separated into 5 major fractions, each comprising 4 subunits. It has a molecular weight of 128,000 Daltons. Each isoenzyme comprises 4 polypeptide chains with a molecular weight of 32,000 Daltons each. 2 different polypeptide chains designated H for the heart and M for the muscle combine in 5 arrangements to yield the 5 major isoenzyme fractions. This table class indicates the tissue localization of the lactate dehydrogenase isoenzymes and the major disorders associated with elevated levels. LD1, which is HHHH for its polypeptide chain, migrates most quickly toward the anode, followed in sequence by the other fractions. That's LD2, HHHM. That's its polypeptide chain. For LD3, it has HH and MM. So HHMM. LD4 has 1H and 3 M's or HMMM. And for LD5, that's 4 M's, MMMM for the polypeptide chains. LD5 migrates the slowest. In the sera of healthy individuals, the major isoenzyme fraction is LD2, followed by LD1, LD3, LD4, and LD5. LD1 and LD2 are present to approximately the same extent in the tissues, which can be seen from this table. However, cardiac tissue and red blood cells contain a higher concentration of LD1. Therefore, in conditions involving cardiac necrosis or acute myocardial infarction, and also intravascular hemolysis, The serum levels of lactate dehydrogenase 1 or LD1 will increase to a point at which they are present in greater concentration than LD2, which results in a condition known as the LD flipped pattern, wherein lactate dehydrogenase 1 or LD1 is greater than LD2. This flipped pattern is suggestive of acute myocardial infarction. However, LD is not specific to cardiac tissue and is not preferred marker for diagnosis of AMI. The LD1 LD2 ratios greater than 1 also may be observed in hemolyzed serum samples. Elevations of LD3 occur most frequently with pulmonary involvement and are also observed in patients with various carcinomas. The LD4 and LD5 isoenzymes are found primarily in liver and skeletal muscle tissue, with LD5 being the predominant fraction in these tissues. LD5 levels have greatest clinical significance in the detection of hepatic disorders, particularly intrahepatic disorders. The disorders of skeletal muscle will also reveal elevated LD5 levels, as depicted in the muscular dystrophies. A sixth LD isoenzyme has been identified, which migrates cathodic to LD5. LD6 is alcohol dehydrogenase, and in reporting studies, LD6 has been present in patients with arteriosclerotic cardiovascular failure. It is believed that its appearance signifies a grave prognosis and impending death. LD5 is elevated concurrently with the appearance of LD6, probably representing hepatic congestion due to cardiovascular disease. It is suggested, therefore, that LD6 may reflect liver injury secondary to severe circulatory insufficiency. Lactate dehydrogenase has been shown to complex with immunoglobulins and to reveal atypical bands on electrophoresis. LD complex with IgA and IgG usually migrates between LD3 and LD4. This macromolecular complex is not associated with any specific clinical abnormality. Analysis of lactate dehydrogenase isoenzymes can be accomplished by electrophoresis, by immunoinhibition or chemical inhibition methods, or by differences in substrate affinity. Because of limited clinical utility, such tests are not commonly used. The electrophoretic process or procedure has been widely used historically, but after electrophoretic separation, the isoenzymes can be detected either fluorometrically or colorimetrically. Lactate dehydrogenase can use other substrates in addition to lactate, such as alpha hydroxybutyrate. The H subunits have a greater affinity for alpha hydroxybutyrate than to the M subunits. This has led to the use of this substrate in an attempt to measure the LD1 activity. Remember, LD1 has a polypeptide chain of H, 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 and this chemical assay, known as the measurement of alpha hydroxybutyrate dehydrogenase activity, is used to separate a distinct enzyme and considered to represent the LD1 activity of the total lactate dehydrogenase. However, alpha hydroxybutyrate dehydrogenase activity is not entirely specific for the LD1 fraction because LD2, LD3, and LD4 also contain varying amounts of the H subunit. Hydroxybutyrate dehydrogenase activity is increased in these conditions in which the LD1 and LD2 fractions are increased. Lactate dehydrogenase is commonly used to measure lactate and pyruvic acids or as a coupled reaction. For the sources of error for lactate dehydrogenase class, remember that erythrocytes contain an LD concentration approximately 100 to 150 times that found in serum. Therefore, any degree of hemolysis should render a sample unacceptable for analysis. Lactate dehydrogenase activity is unstable in serum regardless of the temperature at which it is stored. If the sample cannot be analyzed immediately, it should be stored at 25 degrees Celsius and analyzed within 48 hours. LD5 is considered to be the most labile isoenzyme. The loss of activity occurs more quickly at 4 degrees Celsius than at 25 degrees Celsius. So, serum samples for LD isoenzyme analysis should be stored at 25 degrees Celsius and analyzed within 24 hours of collection. Lactate dehydrogenase class catalyzes the interconversion of lactic and pyruvic acids using again the coenzyme what again? The nicotinamide adenine dinucleotide. And so, this is the reaction equation. There are actually four methods, the Berger-Broida, Wroblewski-Cabot, and the forward or direct reaction is known as the Wacker method. For the forward method class, the reaction can proceed from lactate to pyruvate. While Wroblewski-Ledoux, it makes use of a reverse or indirect direction or reaction, and its reaction equation would be from pyruvate to lactate. Both Wacker method and Wroblewski-Ledoux method has been used in clinical assays, but the rate of the reverse reaction is approximately 3 times faster, allowing smaller sample volumes and shorter reaction times to happen. However, the reverse reaction is also more susceptible to substrate exhaustion and loss of linearity. The optimal pH for the forward reaction is 8.3 to 8.9, while for the reverse reaction, it is 7.1 to 7.4. Let's now proceed to creatine kinase. Creatine kinase class is an enzyme with a molecular weight of approximately 82,000 Daltons that is generally associated with ATP regeneration in contractile or transport systems. Its predominant physiologic function occurs in muscle cells, where it is involved in the storage of high-energy creatine phosphate. Every contraction cycle of muscle results in creatine phosphate use with the production of ATP. This results in relatively constant levels of muscle ATP. Creatine kinase is widely distributed in tissue with highest activities found in skeletal muscle, heart muscle, and brain tissue. CK is present in much smaller quantities in other tissue sources including the bladder, placenta, gastrointestinal tract, thyroid, uterus, kidney, lung, prostate, spleen, liver, and pancreas. Due to the high concentrations of CK in muscle tissue, creatine kinase levels are frequently elevated in disorders of cardiac and skeletal muscle. The CK level is considered a sensitive indicator of acute myocardial infarction and muscular dystrophy, particularly the Duchenne type. Extreme elevations of CK occur in Duchenne type muscular dystrophy with values reaching 50 to 100 times the upper limit of normal. Although total CK levels are sensitive indicators of these disorders, they are not entirely specific indicators as CK elevation is also found in various other abnormal cardiac and skeletal muscle conditions. Levels of creatine kinase also vary with muscle mass and therefore may depend on gender, race, degree of physical conditioning, and age. Elevated CK levels are also occasionally seen in central nervous system disorders such as strokes, seizures, nerve degeneration, and central nervous system shock. The damage to the blood-brain barrier must occur to allow enzyme release to the peripheral circulation. Other pathophysiologic conditions in which elevated CK levels occur are hypothyroidism, malignant hyperpyrexia, and Reye's syndrome. Serum CK levels and CK progesterone ratio have been useful in the diagnosis of ectopic pregnancies. Total serum CK levels have also been used as an early diagnostic tool to identify patients with Vibrio vulnificus infections. Because enzyme elevation is found in numerous disorders, the separation of total CK into its various isoenzyme fractions is considered a more specific indicator of various disorders than total levels. Typically, the clinical relevance of CK activity depends more on isoenzyme fractionation than on total levels. CK occurs as a dimer consisting of two subunits that can be separated readily into three distinct molecular forms. The three isoenzymes have been designated as CKBB, or the brain type, the CKMB, which is known as the hybrid type, and the CKMM is known as the muscle type. On electrophoretic separation, CKBB will migrate fastest toward the anode and is therefore called CK1. CKBB is followed by CKMB, or the CK2, and finally by CKMM, or CK3, exhibiting the slowest mobility. In this table here, class, it shows or indicates the tissue localization of the isoenzymes and the major conditions associated with elevated levels of each. Separation of a CK isoforms may also be visualized by high voltage electrophoretic separation. The major isoenzyme in the sera of healthy people is the MM4, or the CKMM form, or the CK3. Values for the MB, or the CK2 isoenzyme, range from undetectable to trace that's less than 6% of total CK. It also appears, class, that CKBB is present in small quantities in the sera of healthy people. However, the presence of CKBB in serum depends on the method of detection. While most techniques cannot detect CKBB in normal serum. Again, as I've said, CKMM is the major isoenzyme fraction found in striated muscle and normal serum. Skeletal muscle contains almost entirely CKMM with a small amount of CKMB. The majority of CK activity in heart muscle is also attributed to CKMM, with approximately 20% as a result of CKMB. Normal serum consists of approximately 94% to 100% CKMM, and that means injury to both cardiac and skeletal muscle accounts for the majority of cases of CKMM elevations. Hypothyroidism also results in CKMM elevations because of the involvement of muscle tissue. That means there is already increased membrane permeability. And the effect of thyroid hormone on enzyme activity and possibly the slower clearance of CK as a result of slower metabolism. Mild to strenuous activity may contribute to elevated CK levels, as may intramuscular injections. In physical activity, the extent of elevation is variable. However, the degree of exercise in relation to the exercise capacity of the individual is the most important factor in determining the degree of elevation. Patients who are physically well conditioned show lesser degrees of elevation than do patients who are less conditioned. Levels may be elevated for as long as 48 hours following exercise. CK elevations are generally less than 5 times the upper limit than normal following intramuscular injections and usually not apparent after 48 hours, although elevations may persist for 1 week. The predominant isoenzyme for this is still CKMM. The quantity of CKBB in the tissue is usually small. The small quantity, coupled with its relatively short half-life, which is 1 to 5 hours, results in CKBB activities that are generally low and transient and not usually measurable when tissue damage occurs. Highest concentrations are found in the central nervous system, the gastrointestinal tract, and the although brain tissue has high concentrations of CK, serum rarely contains CKBB of brain origin. It is because of its molecular size, which is 80,000 daltons, its passage across the blood-brain barrier is hindered. However, when extensive damage to the brain has occurred, significant amounts of CKBB can sometimes be detected in the serum. It has also been observed that CKBB may be significantly elevated in patients with carcinoma of various organs. It has been associated with untreated prostatic carcinoma and other adenocarcinomas. Because of this, CKBB may be a useful tumor-associated marker. And the most common causes of CKBB elevations are central nervous system damage, tumors, childbirth, and the presence of macro-CK. Macro-CK class is an enzyme immunoglobulin complex. The value of CK isoenzyme separation can be found principally in the detection of myocardial damage. Cardiac tissue contains significant quantities of CKMB, approximately 20% of all CKMB, whereas CKMB is found in small quantities in other tissue, and myocardium is essentially the only tissue from which CKMB enters the serum in significant quantities. Demonstration of elevated levels of CKMB greater than or equal to 6 of the total CK is considered a good indicator of myocardial damage, particularly acute myocardial infarction. In the laboratory class, aside from testing for CKMB, we also test for troponins. So these are also non-enzyme proteins that have been more specific and may elevate in the absence of CKMB elevations. Following myocardial infarction, the CKMB levels begin to rise within 4 to 8 hours, and they peak at 12 to 24 hours and return to normal levels within 48 to 72 hours. This time frame must be considered when interpreting CKMB levels. CKMB activity has been observed in other cardiac disorders. Therefore, increased quantities are not entirely specific for AMI, but probably reflect some degree of ischemic heart damage. The specificity of CKMB levels in the diagnosis of AMI can be increased if interpreted in conjunction with lactate dehydrogenase isoenzymes and or troponins, and if measured sequentially over a 48-hour period to detect the typical rise and fall of enzyme activity seen in AMI. The CKMB isoenzyme has also been detected in the sera of patients with non-cardiac disorders. Creatine kinase catalyzes both forward and reverse reactions involving phosphorylation of creatine or ADP. Typically, for analysis of CK activity, this reaction is coupled with other enzyme systems, and a change in absorbance at 340 nanometers is determined. The forward reaction is coupled with the pyruvate kinase lactate dehydrogenase NADH system and proceeds to the equation found on the screen. This forward or direct reaction is called the Tanzer-Gilbarg assay and maintains the pH at 9.0. The reverse reaction proposed by Oliver and modified by Rosalki, that's why it's Oliver-Rosalki, the reverse or indirect method, is the most commonly performed method in the clinical laboratory. The reaction proceeds 2 to 6 times faster than the forward reaction, depending on the assay conditions, and there is less interference from side reactions. The optimal pH for the reverse reaction is 6.8. CK activity in serum is unstable, being rapidly inactivated because of oxidation of sulfhydryl groups, and inactivation can be partially reversed by the addition of sulfhydryl compounds to the assay reagent. Compounds such as N-acetylcysteine, mercaptoethanol, and thioglycerol, and dithiothietol are among those used. Still the same, hemolysis of serum samples may be a source of elevated CK activity. As it is being said, erythrocytes are virtually devoid of CK. However, they are rich in adenylate kinase activity. AK reacts with ADP to produce ATP, which is then available to participate in the assay reaction, causing falsely elevated CK levels. This interference can occur with hemolysis of greater than 320 milligrams per liter for hemoglobin, which releases sufficient adenylate kinase to exhaust the AK inhibitors in the reagent. Trace hemolysis causes little, if any, CK elevation. Serum should be stored in a dark place because CK is inactivated by light. Activity can be restored after storage in the dark at 4 degrees Celsius for 7 days or at negative 20 degrees Celsius for 1 month when the assay is conducted using sulfhydryl activator. Because of the effect of muscular activity and muscle mass on CK levels, it should be noted that people who are physically well trained tend to have elevated baseline levels, and that patients who are bedridden for prolonged periods may have decreased CK activity. By the way, what's adenylate kinase means? Remember that AK is an enzyme released from erythrocytes in hemolyzed samples and appearing as a band cathodal to CKMM. This adenylate kinase may interfere with chemical or immunoinhibition methods, causing a falsely elevated CK or CKMV value. Methods used for the measurement of CK isoenzymes include electrophoresis, ion exchange chromatography, and several immunoassays, including radioimmunoassay and immunoinhibition methods. Although mass methods are more sensitive and preferred for quantitation of CKMB, electrophoresis has been the reference method. CK or creatine kinase relative index is an expression of the percentage of the total CK that is attributed to CKMB. This is computed to know possible release of the CKMB from non-cardiac tissues when total CK is very high. Aldolase. This is a glycolytic enzyme that splits fructose 1,6-diphosphate into 2 triose phosphate molecules in the metabolism of glucose. The other name for aldolase, which is obvious, fructose 1,6-diphosphate aldolase. This enzyme has increased levels in skeletal muscle disease, leukemia, hemolytic anemia, and hepatic cancer. The different isoenzymes for aldolase would be Aldolase A, which is found predominantly in the skeletal muscles, Aldolase B, mostly found in the WBC or white blood cells, in the liver, and also in the kidneys. And lastly, Aldolase C is predominantly found in the brain tissue. Actually, there are a lot more enzymes, but these are some of the other clinically significant enzymes. So I'll be giving 7 more. Let's start with 5-nucleotidase. This is a phosphoric monoester hydrolase predominantly secreted from the liver. This nucleotidase enzyme is involved in the hydrolysis of a nucleotide to form a nucleoside and a phosphate. Due to this role, Nucleotidase is known as a hydrolytic enzyme. Nucleotidase also plays a catalytic role in the hydrolysis process, and it converts a number of different nucleotide molecules. 5-nucleotidase class is also a marker for hepatobiliary diseases and infiltrative lesions of the liver. It is also specific for cholestasis or damage to the intra or extrahepatic biliary system. 5-nucleotidase is found primarily in the intestine, in the brain, in the heart, even in the pancreas. The reference range would be from 0 to 1.6 units. Greater than normal levels may indicate flow of bile from the liver, which is blocked. So that's cholestasis, the flow of bile from the liver because it's blocked. Heart failure, hepatitis, or if there's an inflamed liver, and also lack of blood flow to the liver. The deficiency of this enzyme, on the other hand, can cause non-spherolytic hemolytic anemia. Another enzyme would be ceruloplasmin. Ceruloplasmin class is a protein that is made in the liver. It stores and carries copper from the liver into the bloodstream and to the other parts of the body that needs copper. Copper is a mineral that is found in several foods that includes nuts, chocolates, mushroom, shellfish, and even liver meat. This enzyme is also considered a marker for Wilson's disease, or otherwise known as hepatolenticular disease. If suspicion of Wilson disease is high, order a ceruloplasmin level. The result of this will be less than 20 milligrams per deciliter, which a normal ceruloplasmin level would be 20 milligrams to 40 milligrams per deciliter. These are the following clinical manifestations of Wilson's disease. Next would be ornithine carbamoyl transferase. It is an indicator also for hepatobiliary diseases, but ornithine transcarbamylase deficiency is a rare genetic condition that causes ammonia to build up in the blood. The condition, more commonly called OTC deficiency, is more common in boys than girls and tends to be more severe when symptoms emerge shortly after birth. The severe form of OTC deficiency occurs in some affected males anywhere between 24 hours to a few days after birth, usually following a protein feeding. Initial symptoms may include refusal to eat, poor sucking, vomiting, progressive lethargy, and irritability. Reference range would be 8 to 20 microunits per ml. We also have true cholinesterase or pseudocholinesterase. Acetylcholinesterase is involved in the termination of impulse transmission, that's by rapid hydrolysis of the neurotransmitter acetylcholine in numerous cholinergic pathways in the central and peripheral nervous systems. Its primary role class is to terminate neuronal transmission and signaling between synapses to prevent acetylcholine dispersal and activation of nearby receptors. Cholinesterase is also an index of parenchymal function and is secreted by the liver. This is also used to monitor the effect of muscle relaxants such as succinylcholine after every surgery. Acetylcholine also class is a marker for insecticide or pesticide poisoning. Since this enzyme is inhibited by organophosphates, that is why it is a marker for organophosphate poisoning. This means that the result after enzymatic activity, if the patient has organophosphate poisoning, the acetylcholinesterase levels would be low. The methods used in order to test for cholinesterase or pseudocholinesterase would be Elman technique and potentiometry. The reference values would be 0.5 to 1.3 pH units, and the sample of choice would be plasma. Angiotensin converting enzyme, or also known as peptidyl dipeptidase A or kinase 2. This enzyme class is a central component of the renin-angiotensin system, which controls what? Blood pressure by regulating the volume of fluids in the body. It converts the hormone angiotensin 1 to the active vasoconstrictor angiotensin 2. ACE is a possible indicator of neuronal dysfunction such as Alzheimer's disease. So the specimen used for this in testing will be the cerebrospinal fluid. ACE will be increased in diseases such as sarcoidosis, acute and chronic bronchitis, and even in leprosy. The main source of angiotensin-converting enzyme class comes from the macrophages and epithelioid cells. Next would be gamma-glutamyl transamin peptidase or gamma-glutamyl transferase. This enzyme class is involved in the transfer of the gamma-glutamyl residue from gamma-glutamyl peptides to amino acids, water, and other small peptides. In most biologic systems, glutathione serves as the gamma-glutamyl donor. The specific physiologic function of gamma-glutamyl transferase has not been clearly established, but it is suggested that GGT is involved in peptide and protein synthesis, regulation of tissue glutathione levels, and the transport of amino acids across cell membranes. GGT activity is found primarily in tissues of the kidney, brain, prostate, pancreas, and liver. Clinical applications of assay, however, are confined mainly to evaluation of liver and biliary system disorders. In the liver class, GGT is located in the canaliculi of the hepatic cells, and particularly in the epithelial cells lining the biliary ductules. Because of these locations, GGT is elevated in virtually all hepatobiliary disorders, making it one of the most sensitive of enzyme assays in these conditions. Higher elevations are generally observed in biliary tract obstruction. Within the hepatic parenchyma, GGT exists to a large extent in the smooth endoplasmic reticulum and is therefore subject to hepatic microsomal induction. Therefore, GGT levels will be increased in patients receiving enzyme-inducing drugs such as warfarin, phenobarbital, and phenytoin. Because of the effects of alcohol on GGT activity, elevated GGT levels may indicate alcoholism, particularly chronic alcoholism. Generally, enzymes elevations in persons who are alcoholics or heavy drinkers range from 2 to 3 times the upper limit, although higher levels have also been observed. GGT assays are useful in monitoring the effects of abstention from alcohol and are used as such by alcohol treatment centers. Levels usually return to normal within 2 to 3 weeks after cessation, but can rise again if alcohol consumption is resumed. Because of the susceptibility to enzyme induction, any interpretation of GGT levels must be done with consideration of the consequent effects of drugs and alcohol. Brief recap: gamma-glutamyl transferase is associated with drug and alcohol abuse. GGT levels are also elevated in other conditions such as acute pancreatitis, diabetes mellitus, and myocardial infarction. The source of elevation in pancreatitis and diabetes is probably the pancreas. But The source of GGT in myocardial infarction class is still unknown up to this day. GGT assays are of limited value in the diagnosis of these conditions and are not routinely requested. GGT activity is also useful in differentiating the source of an elevated alkaline phosphatase level because GGT levels class are normal in skeletal disorders and also during pregnancy. It is also particularly useful in evaluating hepatobiliary involvement in adolescents because ALT activity will invariably elevated as a result of bone growth. The most widely used accepted substrate for use in gamma-glutamyl transferase analysis is the gamma-glutamyl para-nitroanilide. The gamma-glutamyl residue is transferred to a glycyl glycine, releasing para-nitroaniline, which is a chromogenic product with a strong absorbance at 405 to 420 nanometers. Gamma-glutamyl transferase activity is stable with no loss of activity for 1 week at 4 degrees Celsius. Hemolysis also does not interfere with GGT levels because the enzyme is lacking in erythrocytes. This means it is not found inside red blood cells. The reference range of GGT in males is 6 to 55 units per liter at 37 degrees Celsius. Or in SI units, that's 0.1 to 0.9 microcatal per liter. And in females class, that's 5 to 38 U per L at 37 degrees Celsius or 0.1 to 0.6 microcatal per liter. The last but not the least, other clinically significant enzymes, that would be glucose 6-phosphate dehydrogenase. G6PD class is an oxidoreductase that catalyzes the oxidation of glucose 6-phosphate to 6-phosphogluconate or the corresponding lactone. This reaction is important as it is the first step in the pentose phosphate shunt of glucose metabolism with the ultimate production of NADPH. What is NADPH again? It stands for nicotinamide adenine dinucleotide phosphate. NADPH class is needed because it will reduce glutathione and so it protects the red blood cells from oxidative damage. G6PD is also a newborn screening marker and babies in the hospital are being tested once they are born after like 24 to 48 hours. The tissue sources for G6PD include the adrenal cortex, the spleen, thymus, lymph nodes, the lactating mammary gland, and erythrocytes. Little activity is also found in normal serum. A deficiency of this enzyme can lead to drug-induced hemolytic anemia. So what are the types of drugs that could cause hemolytic anemia? Those are primaquine and also anti-malarial drugs. Most of the research interest in G6PD focuses on its role in the erythrocytes. Here, it functions to maintain NADPH in its reduced form. And an adequate concentration of NADPH is required to regenerate sulfhydryl-containing proteins such as glutathione from the oxidized to its reduced state. Glutathione in the reduced form in turn protects the hemoglobin from inside the red blood cells from oxidation by agents that may be present in the cell. As what I have said, the lack of G6PD in the body of the patient's class would cause hemolytic anemia. And there is already inability to maintain the reduced glutathione levels. Thus, the erythrocytes are exposed to oxidizing agents, making hemolysis inevitable. G6PD deficiency is an inherited sex-linked trait. The disorder can result in several different clinical manifestations, and one of which is drug-induced hemolytic anemia. Remember that? And when exposed to an oxidant drug, affected individuals experience a hemolytic episode, and the severity of the hemolysis is related to the drug concentration taken by the patient. G6PD deficiency is most common in African Americans but has reported in virtually every ethnic group. Increased levels of G6PD in the serum have been reported in acute myocardial infarction and megaloblastic anemias. No elevations are seen in hepatic disorders. G6PD levels, however, are not routinely performed as diagnostic aids in these conditions. A red cell hemolysate is used to assay for deficiency of the enzyme. Serum is used for evaluation of enzyme elevations. The reference range for G6PD is 7.9 to 16.3 units per gram per hemoglobin, or in SI units, that's 0.1 to 0.3 UCAT per grams per hemoglobin. That is all. Thank you so much for listening. I hope you've learned something new from me today. May God bless us all.